today. I wonder if I'm able to share my video.
Yes, you should be able to share your video.
Okay, just a minute. Ah, thank you. Thank you. All right. So thank you very much, everybody, for joining in. Good afternoon. My name is Elo Mapelu from KENCO Kenya. I'm also chairman of the board of KENCO, which is the Kenya Network of Cancer Organization. Today's webinar is on acute leukemia, and we will be having Dr. Matilda to speak to us. We'll also be having Francis Bomer from KNH to speak to us. And we have Sarah Mararo and Livingston Simiyu from KENCO also to speak to us. But before we get started, I just want to remind you that you can send your questions once the presenters start. You can share your questions on the chat so that we can pick it up, and the panelists will be able to respond to your questions. And those who are asking, I've already started receiving requests for points. At the end of the presentation, you will be informed about how to get your CPD points. So just stay tuned until then, you'll be informed about that. Today's webinar has been made possible by KNH, of course, our friends from KENCO and of course KENCO, and we also support from Acute Leukemia Advocates Network, Alan, who oversee the advocacy activities of all advocates in the world who are active in leukemia, acute leukemia advocacy. And we are grateful to them and to everyone who has made this possible. And again, to everyone who has joined in. I can see our numbers are really good. And I don't want to take up any more time. I want us to get started as soon as we can. Were you able to get KNH Research? Were you able to get Dr. Matilda's slides?
Yes, we were.
Okay. All right. So
yes.
Yeah. So I'd like to invite Dr. Matilda, a consultant oncologist from KNH, who has worked very closely with the acute leukemia patients and generally all leukemia patients, to just give us an overview of acute leukemia. I know it's a huge topic, this one, and she's going to share with us an introduction today. I'm sure we'll be able to get another time to get deeper into discussion on acute leukemia. There's a whole lot that we need to learn, partly because being a rare cancer, we don't come across a lot of information out there on acute leukemia and generally all leukemias. So today is we have the honor to learn from Dr. Matilda just a bit about it, and hopefully we can progress on with another session to delve deeper into it. So Dr. Matilda, if you're ready, you're welcome to share with us. Karibu.
All right, thank you very much. Good afternoon, everyone. And I would want to take this opportunity to appreciate the organizers for giving me a chance to talk about this important disease. Because for this one, we need everyone on board in terms of making a difference, right from the grassroots up to the referral level. So I hope that you can hear me clearly, if someone can confirm that.
Yes, we can hear you, Dr.
All right, thank you very much. And thanks to the research team for projecting the slides. We can move on to the next one. So as has been said, acute leukemia is a very wide topic. So I'll just try and give us an overview, looking at the definitions, a bit about epidemiology, clinical presentation, just take a bit of time there, because that's when we interact with these patients most when they come to our facilities, so that we can then be able to do the right diagnostics and or even the initial ones before we send them to the referral facilities. Next slide, please. So acute leukemia is really a broad a group of conditions, and and I've used the word heterogeneous because as much as we talk mostly about two, but we shall see there are more disease entities, even within those select groups, it's really not just one disease. So it's a heterogeneous group of blood cancers which arise from a clonal expansion of malignant hematopoietic precursor cells. So those words are important because these are the precursor cells are then the ones that, lead to your downstream generation of your more mature cells. So if you're to put it in layman's terms, to someone, because most of the times when people hear of cancers, they correlate it with solid tumors. So one of the challenges we have all the time is trying to explain to the common person what this new diagnosis of leukemia is. But with the more we get to talk about these conditions, then the more awareness there is. So, and clonal, why? Because you're having one particular cells, and as we shall see later, sometimes even within one malignancy, you have different types of cells. So by that, you have that population or that clone increasing. And this is due to genetic factors and things that affect the genes. We call those epigenetic changes. So in terms of the broad groups, you can have the lymphoid lineage being affected, in which case you'll reference that to as acute lymphoid leukemia. You can have the myeloid lineage being affected, in which you'd reference that as acute myeloid leukemia. Sometimes what would happen is that you have these immature cells displaying characteristics of both lineages. So, and therefore the term by phenotypic leukemia, but in the new classification, it's acute leukemia with an ambiguous lineage is what it's been described as. Then you have an entity called lymphoblastic lymphoma. And, we categorize lymphomas as something, a totally separate hematological malignancy. But lymphoblastic lymphomas tend to be aggressive and behave just like the acute lymphoid leukemias. And usually the term difference is based on what the percentage of the blasts is in the bone marrow. So when you do a bone marrow, if your bone marrow blasts are more than 25%, then you would call that acute lymphoid leukemia. If this patient has lymph node or masses, usually they end up being mediastinal masses, but then you do a bone marrow and it's less than 25% blast, then you'd call it lymphoblastic lymphoma. But when it comes to treatment, you would treat it as acute lymphoid leukemia. Next slide, please. So as I've said, usually when you're looking at these malignancies, it's mainly what are the lineages affected. And, also when patients present, we see symptoms as a result of, your red cell population being affected, your white cell population being affected. So patients presenting with recurrent infections, or your platelets being affected and the patients then presenting with the bleeding diathesis. Next slide, please. So in terms of epidemiology, most of the times we reference a lot of data from the West. As Mapelu mentioned, acute leukemias doesn't fall at the top. in terms of, in fact, our local registries, it's, it features above top 10, but around the number 8, number 9 region, depending on male or female. But even in the West, it accounts for 2.5% of all new cancers. Looking at the different data sets, AML is the most common. There's a study that was done at Aga Khan looking just at the lab samples they had received, and this study was looking at the immunophenotype, that is the special characteristics of the cell. Is this a T cell ALL, B cell ALL? And that time they found there was more B cell ALL. In the West, you'll realize that the peak for these adult leukemias is usually 68 to 70 years. But looking at the study that was, published from the Kenyan, although this was a small population, you can see the median age was 29.5. And there's also a study that was reported, this was specifically on AML by the MTRH group in Eldoret, and the median age in that population set was 40 years. And in all these studies, it tends to have a male predominance. The next slide just shows, although this is much older because we have a GlobalCan 2022, you can see where Kenya features. We have, an estimated incidence of 3.5 to 4.6 cases per 100,000. But I think a lot of that, may change even as we are seeing, a rapid increase in the number of cases. Just giving a small snapshot of what we see in our department in the next slide. We are looking at all the cases that we have managed, and this is just inpatient, and specifically those who ended up in our unit. Next slide. We can see there's been a predominance on AML mainly compared to ALL. But because this is not data that has been sorted, hopefully by the end of the year, we can have something more organized published, because there's some work that's to begin. So like you have a group there as pancytopenia, but when you work up these patients, some of them end up falling in either the AML or the ALL category, or even aplastic anemia. So even in our, in this small cohort, you would say you still have a predominance of AML patients. Next slide, please. So if we are able to get to the next slide. Thank you. So the next question usually, and we can move on to the next slide, is how do I get leukemia? This is a common question, patients ask, and especially for those patients whose presentation is not as dramatic. They've been fine. Maybe it's just that week or the past month that they've been feeling a bit of fatigue. They go to an outpatient facility, they have their blood works done, and they're told there's something that's not looking normal, and therefore we need to do further tests. And then you end up with a diagnosis of acute leukemia. And usually the question is, how did I get here? And that's really a complex question, because many times when patients ask that, they may be looking for a simple answer. But the genesis of cancer and leukemias is more than just one step. And usually it's a multi-step process where you have this cell. Many times you have an initiating event that then begins this process of alteration in terms of the cells and how they're able to divide, and then evading the normal checks and balances in the body in terms of the regulation systems that would destroy the abnormal cells. And then you have also sometimes external stressors, and that's what many people want to look at. But a lot of what drives the genesis of malignancies is mostly at the genetic levels, that you have these mutations, you have driver mutations, then you have multiple mutations that happen thereafter that then result in this cell population becoming abnormal and then replicating and proliferating to then present as leukemia. Next slide, please. And you can see this can happen at various levels. We talked about the genetics, so you know the chromosomal material itself, but then epigenetic, and epigenetic is more around the issues of the other things that, so like the diagram to the right there where you have transcription factors, those can have mutations that then cause abnormalities that predispose someone to get leukemias. You can have issues with how these proteins, the histones are the proteins that they tend to wrap around the genetic material in the chromosome folds on itself. And you can have changes occurring because of methylation. And you have drugs that target that. So you can have mutations at that level, and the mutations that occur at this level are now, you know, those that are epigenetic. So you have the changes that are the genetic level, and then you have also these other mutations and changes that can occur that affect the proteins that relate closely to the gene, and those are the epigenetic changes. And these can either be point mutations, they can either be translocation, and all this is then what leads to this malignant proliferation of cells. You have within the normal mechanism a way the body gets rid of abnormal cells. Thanks. It's okay. We can move to the next slide. And the next slide really just showing you have that lymphoid progenitor cells. Sometimes you have inherited genetic factors that then put you in this pattern of being predisposed, that then when you get an initiating event, it's then easier to move along, you know, that path of the genesis of these leukemia cells. And then these cells get trapped in the immature state. And this process even happens at the level of treatment, in terms of when you're treating patients, you're treating them so that you get rid of this abnormal clone of cells. But sometimes when you see this around patients who either have refractory disease or patients who relapse, that you can, you know, at the bottom of the diagram there, you have these cells with a black dot. I would call that the nucleus, the black nucleus, and then the lighter nucleus. And you know, this patient gets chemotherapy, you get rid of one clone, but then you have a clone that is sustained, and that becomes the clone that drives the relapse or the progressive or refractory disease. So as much as we would want simple answers, or patients would really want of us to give them simple answers, the truth is that it's not that simple. And so usually the easiest thing I tell patients is there are multiple factors that lead to the development of cancer, and majority of them have little to do with, you know, what someone does or doesn't do. Yes, there may be some in some cases, we have documented evidence of environmental, you know, exposures, and that we know has been documented in literature and in studies, things like, you know, the Hiroshima and the Nagasaki. But really in our population, I think there's still a lot to be done in terms of documenting for us what our environmental exposures would be. Next slide, please. So the next thing then is, when does one suspect acute leukemia? And sometimes you have patients who have, you know, characteristic presentations because they have a high number of these leukemic cells in the bone marrow, and therefore the normal erythropoiesis is affected. Therefore, these patients present with symptomatic anemia, so fatigue, easy fatigability. They're not able to carry out their daily duties, or recurrent infection because the granulopoiesis, that's the white blood cells, is affected, or bleeding tendencies because of low platelets. And this can apply across whether it's acute lymphoid or acute myeloid leukemia. For lymphoblastic lymphoma patients, they usually present with either constitutional symptoms or sometimes symptoms because of the compression effect of huge mediastinal mass, and unless also they have significant bone marrow involvement. Sometimes they may be constitutional things like weight loss, fever, so it's always good to ask those questions. Sometimes they may be bone pain, and this I've seen very characteristic, especially for patients with acute lymphoid leukemia. And sometimes this bone pain can be very severe that they require opioids. And that's just because of that bone marrow expansion because of the rapidly proliferating leukemic cells. We know that in conditions like acute myeloid leukemia, because of infiltration by the blasts, the patients can have gingival hypertrophy, and this is quite characteristic that if you have a patient with the other symptoms we've mentioned and there's gingival hypertrophy, you can actually highly suspect, does this patient have AML? Also, they can have masses, myeloid sarcomas, they can be swellings in the eyes and have chloromas, they can be infiltrations in the skin and have leukemia cutis, and this tend to really portend more aggressive disease. Sometimes for patients, especially with the myeloid leukemias, and especially those who have transformed, from like CML, you may have associated things like hearing impairment, and also depending on the involvement, patients with ALL sometimes would have neurological deficits. I've seen a few patients with AML presenting with lower limb weakness because of infiltration or involvement of the cord. This is not common but can occur as well. So really, if you're seeing a patient who has easy bruising, has PTK, has gum bleeding, sometimes all that may be is just gum bleeding. Someone is brushing their teeth and they notice they're bleeding, or they go and have a tooth extraction. That's how some of the patients get. So if we have any dentists, any ophthalmologists, before you do any procedure, please, we need to do a simple blood count and a coag, just an INR and APTT, because sometimes these patients will go to a dentist, they have an infected tooth, or they have dental caries, have their tooth removed, and then they have this bleeding that doesn't stop. Next slide, please. So having that high index of suspicion. So in terms of diagnostics then, so you have this patient who has come, they have, maybe they may not have all those classic symptoms. I think there is a slide that's missing. There should be one on diagnostics, thank you, okay. You have a simple blood count and looking at all the parameters of the total blood count. What's this patient's hemoglobin? What's their red cell count? If they have anemia, what is the MCV? What is their white blood cell count? What are the differentials? So you want a white count with the differentials, because that can give you sometimes a picture of what's happening. Is there, if your facility is able to do that, having a peripheral blood film is very informative, because if you see there are abnormal, any abnormality in the counts, then you'd want the peripheral blood film. Sometimes the abnormality in the counts may be very subtle, and especially those who get picked up early. It may just be an anemia of 11, whereas someone's HB usually sits at 13 or 14. or a white count of 2 point something. So also sometimes when we are used to alarming values, we can ignore or write off just the subtle abnormalities. But what I would want to encourage us is where your blood count is not normal, please ask, or where the differential is not normal, please ask for a peripheral blood film from a reliable facility, not the ones which are just copied from the numbers on that's produced by the Coulter counter. So in terms of confirmation, then we would need a bone marrow so that we are able to assess, are there any abnormal cells, blasts? Because sometimes you may have blasts in the peripheral blood, but sometimes you may not have blasts in the peripheral blood. But then and all you have is a pancytopenia picture, that's all the counts are low, or a bicytopenia, you have 2 cell lines which are low. But then when you do the bone marrow, you find that it is packed with blasts. So a bone marrow is an important diagnostic and is important for confirmatory diagnostics. The bone marrow, I've written immunophenotype because usually in the past, we know that a lot of the diagnosis has been based on the morphology, but for many years now, and I would say maybe now in our area, for a couple of years, probably fewer than in the West, we now have better access to immunophenotype. On morphology, sometimes there may be difficulty in saying, is this lymphoid? Is this myeloid? Is this a biphenotypic or an acute leukemia of ambiguous lineage? So that's where your immunophenotype comes. And what is this? This is where, if it's on a trephine biopsy, that you have stains which are used to type the blasts which are seen, so that using the particular stains, you're able to identify, is this a lymphoid or is it a myeloid? And then also, there's something called flow cytometry, which uses colored stains marking particular, the way for HIV, we all know about CD4, CD8. Each of the cells have particular clusters of differentiations that are on them that are diagnostic. The lymphoid, the myeloid, the myeloid, the common progenitor cells of the hematopoietic stem cells. So using that and using color, you can be able to type to see where the cells fall, and this is called a flow cytometry. However, we encourage that this is a test that one should send for either after discussion with a specialist, a hematologist, or it's better to refer, because these tests are expensive. So for instance, you don't want to do a flow cytometry for a patient with chronic myeloid leukemia. That's a waste of their resources. You want them to spend that money on a BCR-able. But for acute leukemias, this is an important test. And then there's also one of the chronic leukemias, the chronic lymphoid leukemia, where this is also a very important test. So, cytogenetics is still out of reach of many of our patients. I would say for our patient population that we serve at KNH, it's really out of reach for most of them. And when we look at cytogenetics, we have conventional cytogenetics where each chromosome is typed so that you're able to pick out any chromosomal abnormalities, or something called a fluorescent in situ hybridization, where, for example, you have an acute myeloid leukemia type previously known as M3, where you have a known translocation between chromosome 15 and 17, and you have probes which have been developed for that. And then you have a test that this test will just look at that particular abnormality. So that's better in terms of you have a quicker turnover, and then also costs more. It's relatively cheaper compared to doing the full conventional cytogenetics. But for us also, conventional cytogenetics is a bit difficult because it's not done in country. So these samples are shipped out. And therefore, most of these samples, because you're depending on working with cells which are that are alive and dividing. So the challenge is by the time the samples are shipped, most of the cells have already, they're not viable. So, and this was even documented by a study that was done by Dr. Gatua, and she looked at looking at the molecular abnormalities in our patients. And unfortunately for all the TEL patients, the conventional cytogenetics, none of the samples had viable cells for that. And so they were only able to do the next generation sequencing, which I've indicated there. Now, so we've basically talked about diagnostic and confirmatory testing, but that's not all the investigations that are done. You'll need to treat these patients. Sometimes they'll have associated issues, whether renal or otherwise. So UECs, liver function tests, are important for conditions like the one that I gave an example of acute promyelocytic leukemia. These patients can have significant bleeding because of the nature of the malignancy, and they tend to have, because of the cells producing a few proteins that mainly tissue factor and something called annexin, these patients can have a DIC-like picture, and therefore their management is also a bit different. So looking at the INR and APTT, fibrinogen levels for all these patients is also important. Serology, sometimes these patients can have infection, HIV with hepatitis B, so that's important. Uric acid and LDH, like in ALL, we'll be using a lot of steroids. So you want to know, does this patient have any predisposition to diabetes or glucose intolerance, so that you either start them on a preventive medication, or if they develop steroid-induced diabetes, then you know it's not that they had an underlying predisposition earlier on. Relevant imaging dependent on the presentations. As we've said, sometimes they may have neurological effect. Anytime you have a patient with low platelets complaining of a severe headache, that's trouble. You need a head CT scan, make sure they're not having a bleed. And then also cardiac evaluation because of the medications that we shall use. Next slide, please. So in terms of classification, next slide. Now, before there used to be a simplified classification, mainly based on morphology. For acute myeloid leukemia, we'll all remember M0 to M7, and M3 was, the one that was mostly talked about because it was the acute promyelocytic leukemia. And for lymphoid, you had L1 to L3, which was the bucket-like. But a lot has changed because this was based on morphology. Next slide, please. Just to help us understand that now, because there is a lot of information, the classification looks at where are these cells? Are they lymphoid? Are they myeloid? Are they mature cells? Are they immature cells in terms of precursor cells? And so this is just sort of, a small diagram just showing how the classification has, I think, in many ways become more complex. And when we look at the next slide, please. So here the concept is mainly lineage, maturity of the cells, where do they fall? And I've just tried to summarize, like for AML. So now there's consideration. We've said, are these mature cells? Are they precursor cells? Are they lymphoid? Are they myeloid? On the earlier slide, we had NK T cells. Are they stromal cells? Are they dendritic cells? So, the entities can really be quite varied. But just breaking it down, like for acute myeloid leukemia, now it's no longer just your M0 to M7, that one actually falls under acute myeloid leukemia, not otherwise specified, which is on the 4th row. There is, because you now have the molecular and genetic tests being done all the time, that you have those acute myeloid leukemias with recurrent genetic abnormalities that have been defined. Like again, the example of APML, acute promyelocytic leukemia, where you have the non-translocation. You have AML that's as a result of myelodysplasia related factors, or AML for patients who had had treatment for with chemotherapy or exposure to radiation in the past, or AML with conditions such as Down syndrome. So you can see the classification has become more complex and also embracing a lot of the other genetic and molecular information, which is now more readily available, not in our setup, but in many places. And the purpose of this is because, one, because of treatment options, but also important in terms of prognostication. Next slide, please. So why is this important? So I've said because of prognostication. So because some of these molecular abnormalities that have been discovered have been able to select patients who do well. So this is the slide shown is looking at AML, that when you do this genetic, the cytogenetics and the molecular testing, you can be able to put these patients in groups. Are they favorable? In which case that this patient would just go through induction chemotherapy and consolidation and they don't need a transplant. Are they intermediate or high risk or poor risk, the adverse risk? In which case, if that patient goes through induction chemotherapy, they need to go straight for transplant. So that's the importance. And the graph on the right just shows you the green is a favorable, and you can see the overall survival for those who have favorable disease is better than those who have adverse disease, which is in red. Next slide, please. So again, this is for acute lymphoid leukemia. So in both the lymphoid and the myeloid leukemias, we look at different factors in terms of trying to risk stratify and prognosticate your patient. You can see for ALL, you have things about, is it B cell, is it T cell, what's the age of the patient, what's the white cell count, and this is picked out of the NCCN guidelines, which is one of the guidelines that is commonly referenced for hematological and even solid tumors. But just again, putting out the point that really the landscape has changed a lot, but for us, we are still long ways away. But I think, there is room for us. There's room for us to get to that level. Next slide, please. So again, just briefly now, when we look at management, there is supportive and there is definitive management, and none is superior to the other. You need both. You can't talk about definitive treatment in acute leukemia overlooking the supportive. In fact, I would say that the supportive treatment is what your definitive treatment is anchored on. And if you don't have that, then it really makes life difficult for managing these patients. Next slide, please. One of colleagues from the ward will talk about the supportive care, so mainly in terms of infection prevention practices, barrier nursing, infection control, blood and blood products is important. I think my appeal, because I know there's a wide reach in terms of who is listening today, is if possible, please transfuse these patients, then send them. Because the challenge many times we have is we receive patients in extremis. You have a patient who is referred from a health facility that can transfuse. with a HB of 2 and low platelets. So you are left, it makes the journey even more difficult for that patient. And you can only imagine for a hospital like KNH, where you get all sorts of referrals, all sorts of emergencies, the challenge and the strain we have on the blood and blood products is quite real. So we know that platelets are not out there as much as blood, but if these patients can be transfused quickly and referred, this will make such a big impact in terms of the patient outcome. And this is a key part of supportive care. So this is something that you can do. Patient has a low HB, transfuse them. Don't write their HB of 2, refer. Transfuse them so that by the time they come, we move to the next level. We know we are looking for platelets. They have a fever. Can we be able to give the appropriate antibiotics? Here, I know there is a challenge, and sometimes we too face that challenge, because in these patients with acute leukemia, the preferred antibiotic where you have neutropenic fever is the broad spectrum antibiotic, and the preferred is tazocine, which may not be available at many facilities. So if you're able to use what is available to you and then refer the patients. And when we think about also prescribing antibiotics, you also want to look at what is the system that is most affected in this patient, so that you can prescribe your empiric antibiotic and then where possible, if you have support of blood cultures, that then you can be able to tailor the antibiotics based on the blood cultures. But many times for these patients, you'll be doing a lot of empiric antibiotics, but because also they have a long journey, you want to make sure you have a wise choice of antibiotics. Next slide, please. So when it comes to principles of treatment, there's no way I would be able to go through the treatment for AML and ALL in these sessions, but just to sort of share with us some of the things that we look at. We know each time you see a patient, what is the best treatment for this patient? You have to optimize them first. So whatever it is, if it's an infection, manage them for that. If they have, sometimes you can have, I've seen a patient with ALL once who they presented in tumor lysis after getting some small dose of steroids. So dependent on what the issue is with your patient, you have to optimize them first and then look and see what is the age of my patient, what are the comorbidities in this patient, because that may impact the type of medication you can use. And most important, what is the performance status of this patient? A patient who is bedridden, you would look at your treatment options differently, or you may not, depending on the diagnosis, be able to offer a treatment option and choose something we call best supportive care. And then disease factors is where we are a bit disadvantaged because we don't have the cytogenetics that's able to risk stratify well for our patients, but that's an important thing in terms of choosing treatment. And we know now, as we shall see in a subsequent slide, that with the identification of mutations, some drugs have been developed that target specific mutations. So these genetic tests and the molecular testing is more than just getting the information, but it's moved to the level where now treatment can be personalized dependent on the mutations or the phenotype of the disease. Then most important, which cannot be ignored, is institutional factors. And this can happen even for us at referral facilities. Like at the moment in our institution, we've had a few transitions, which are hopefully temporary, that have impacted our ability to do intensive inductions. So you cannot overlook, as I said, supportive management. Where are you going to manage this patient? if you don't have isolation, that impacts patient care, supportive care. Do you have the capability to do blood and blood product transfusion when these patients get, when you start treating them and they get cytopenic? So when you're optimizing them is different than when you start treating, because when you start treating them, you need to be ready to intervene when your counts are going down, when their platelets are going down. And then what options are accessible? Is there expertise where you are to manage? And that's where we know for acute leukemia, there's a lot to be done, because at the moment in the country, in terms of public institutions, I think it's only one that's really doing a good job in terms of inductions, and then the other two, we are kind of struggling, but the only 3 centers, that's MTRH, KU, and KNH, that at the moment are able to do that for public facilities, because there's also cost implication for this. So you see, these are things that you'd want to discuss with the patient. So even for us, we have to discuss these options with the patients. If we're not able to do induction, we tell the patient right now, the challenge is not the drugs, but it's the support system. And this is important. And we know right now in the field of medicine, there's a lot that's coming up and being promoted of what we call shared decision making, where as the doctor, you present all the facts in a way the patient can understand, give them the information so that the patient then is able to ask questions, and then together you are able to come to a shared decision making, which then is what you will implement. Next slide, please. So just looking at AML, you have intensive treatment options, which is the induction treatment. Then you have less intense treatment options, which then you'd offer for either when you're not able to support well in terms of the supportive care that we've mentioned. But less intense treatment does not mean there's no supportive care. You still need to support those patients. And then, as I've said, sometimes you would not, especially for AML, if a patient is quite unwell, you would not be able to do, because there's nothing like very little chemo for AML. So sometimes all you're left with is to do best supportive care. Next slide, please. So the next slide just looks at an example, and this is by no means for you to cram or to really, it's just showing in an ideal setting, all the factors that would be playing in terms of management. So the landscape has really changed. For us, we're still at, induce them with chemotherapy, a standard 7 days of cytarabine and 3 days of an anthracycline. But you can see the reason why we were talking about those cytogenetics, those molecular testing, is because you have treatments that would be based on that. For example, in the middle there, you have AML with a FLT3, ITD, or that internal tandem mutation. You have a drug that's been developed that targets that mutation. So for that patient, they'll have the standard 7+3, but a drug called midostaurin that targets that. So the landscape, again, as I've said, has changed. The field has changed. There are now more things to be factored. So you see, in a setup where you have all those things, then when you're looking at patient factors, disease factors, as you're looking at options of treatment, then you sort of have a lot to consider when you come into the treatment phase. Next slide, please. So again, the same. Yes, so, and you can see on this slide, this is just a schema showing you many drugs that are now being developed, looking at specific factors. On the right there, you have PML, RARA, that is acute promyelocytic leukemia, you have something called all-trans retinoic acid that's available locally. So that, and it's the treatment that together with chemotherapy, we don't have arsenic trioxide that can be given for patients with acute promyelocytic leukemia. But again, just to drive home the point that in the field generally, because this is also to update us on what is happening, you know, in the space of leukemia care, that we, you know, when you hear a lot of personalized treatment, so this is being driven by information that is generated from these identifiable mutations and drug developments to target those mutations. Next slide, please. Again, for ALL is a bit different in terms of, you want to see what regimen. You have multi-agent chemotherapy. So for instance, I'll give an example like the hypercivard. Hypercivard stands for hyperfractionated cyclophosphamide because it's broken down to 3 days. So you're not just having 1 day of cyclophosphamide. And then you have vincristine that's given on 2 separate days, adriamycin A, which is given on 1 day, usually around day 4. And then dexamethasone, where you have blocks from day 1 to 4, day 11 to 14. And then interphased therein, you have intrathecal chemotherapy because ALL has a tendency to relapse at sanctuary sites, which is the CNS and also the testes. So a lot of the treatment protocols have within them the intrathecal chemotherapy, but also high doses of 2 drugs, mainly cytarabine and methotrexate, that can then penetrate into the CNS. Then the other different thing about ALL and a few of the AMLs is that you have something called maintenance treatment, whereby if a patient does well, they respond well to the initial treatment and the consolidation, then they go through a 2-year period of maintenance. And the other thing about ALL is, for instance, if a patient is sick and you're optimizing, so long as it's not sepsis, you know, you can put them on steroids, you can put them on a weekly vincristine as you try to optimize them. So for ALL, in some sense, you have kind of options that you can give the patient as you're waiting to stabilize them. I'll give an example of a patient we had last year who is 80 and had just had a subdural hematoma and now was diagnosed with ALL and came to the clinic. And given the support that we had, given his age, given what was happening neurologically, and he also had a small meningioma, you know, that wasn't going to be dealt with, we opted to give this patient less intense treatment, which worked. In fact, the gentleman now has moved on to maintenance treatment, and he has responded to that treatment and is in confirmed remission, both by morphology and immunohistochemistry. So you're always paying attention to who is the patient, what are they able to tolerate, what is my disease, and what do we need to do to best care for this patient. And that if we are not able to offer that, then we refer the patient to a facility where that is possible. But as I've mentioned, this is an area where there's a huge gap in our country because the patients are there. It's very resource intense. In many private facilities for an acute leukemia, you need at least 1 million. For an AML, in fact, maybe 1.5 or something if they end up in an HDU or an ICU setting. Next slide, please. So again, the treatment, as I've mentioned earlier, you know, you have multiple phases of treatment. Next slide, please. So when we follow up this patient, say a patient has finished their treatment, they are now being followed up History is very important. Do they have any concerning symptoms? Clinical exam, if it's lymphoid, looking for your lymphadenopathy, lab monitoring, what's happening to their blood counts. And sometimes those changes are very subtle again, that a patient who's in remission, count recovery, and then their counts start dropping. You need to do a bone marrow evaluation for that patient. For conditions where you have molecular markers that can be tracked. So for example, acute promyelocytic leukemia, we talked about the PML-RARA, that can be monitored along the course of treatment. In ALL, you have an entity where you have the Philadelphia chromosome can be positive. This is a different Philadelphia protein from the one that we see in CML, that can be monitored. And then there are others where you can also have monitoring. There's something called NPM1, but there is that aspect of molecular assessment, but you only do that for the molecular abnormalities that have been found, that you can monitor this, and that when you see that it is increasing, that means an indication that the disease is coming back. So, and follow-up is always important because of the risk of relapse. And this cannot be understated. So if you ever end up with a patient who tells you, oh yes, I was treated for acute leukemia once, you need to ask them, are you following up? And especially the first 5 years are important, but we know even later on, it's important. It's only that the duration may extend as the years move further from the time of the initial treatment. Otherwise, what happens with many of our patients, they feel well, they were really sick at the beginning, so now they're okay, they're able to go on with their duties, money is not there, so they stop coming. Then now they come and tell you, I'm not bleeding, and we are in trouble. So follow-up is really important in these patients. Next slide, please. So thank you very much. And sorry, I think I have taken a lot of time, but I hope I have tried to demystify a little bit about acute leukemias, though rushed, but I hope you have at least picked up something. So, and we are available. I work at Kenyatta Hospital. Our hematology clinics are on Mondays at clinic number 23 at 9 a.m. So if you have patients, you can refer them to that clinic for evaluation. Of course, if they're unwell, they need to be referred. Please transfuse the patients as well. Thank you.
Thank you, Dr. That was very informative. Really appreciate that you made time to take us through that very detailed introduction. And I'm sure going forward, we'll be calling upon you to delve deeper into some various aspects of acute leukemia. And I'm sure from this engagement, we'll be able to know which areas to put more emphasis on. I can see there are quite a number of questions, but allow me to first, before we tackle the questions, to invite Francis Bomer to speak just briefly to us. Francis, I'm sure most of the work has been done by Dr. Matilda, but you'll help us also be able to have a picture of what nursing care is like for acute leukemia patients in KNH. Then after Francis's presentation, I'll invite Dr. back together with Francis to respond to a few questions that have been raised before we proceed. Francis, please take it away.
Thank you so much, Modelo. My name is Francis Bomer. I don't know if I'm
Francis, you are breaking a bit. I can't hear you, Francis. I don't know, did we lose you? Perhaps as we wait for Francis to fix his internet, Dr. I'd like to request you to probably respond to a few questions. There are quite a number that are on our Q&A section.
Thanks. I've been trying to look at some of the questions, and then once Francis is able to join us, he can just let us know. So I think I went through the aspect of his leukemia genetic. Yes, Francis?
You can hear me now?
Yes, that's better. Please go ahead.
Sorry for the interruption. My name is Francis Bomel. I work with Dr. Matilda, specifically in the hemato-oncology ward. So we play a role in terms of supportive management, the way Dr. Matilda emphasized, and we manage these patients. So basically what I'm going to talk about, I'll talk about one, how we assess these patients, and then I'll talk about a little bit of management, though I know Dr. Matilda has really covered much, so I'll narrow myself to the nursing part of it, and then challenges. So patient assessment is key, especially us as nurses, because for us to plan our care, we need to do elaborate assessment for these patients, because due to the ineffective erythropoietic processes and bone marrow failures and toxicities associated with the drugs, is basically the chemotherapy. Most of these patients present with myriad of symptoms, including recurrent infections, anemia, headaches, and even bone pains. And this specific, pain is one of the most common symptoms that these patients, that normally brings this patient to hospital. Otherwise, without pain, most of these patients will expand accumulation of this, because in leukemia, there's well, so
Francis disappeared again. Sorry about that.
Do you want me to address some of the questions?
Yes, please, Dr. As we try to sort out Francis. Maybe you can
All
come in
right.
later after you're done.
Okay. So the just from the top.
And can you hear me?
Francis,
is it okay now? You can hear me now? Okay, isn't it?
Yes, we can hear you. Are you stable now? Did you
yes
fix your internet?
Yes, I fixed. Yes, I fixed. Sorry about that. I really apologize. So
okay. So then maybe then you can run through your slides, and then Dr. Matilda can respond to some of the questions.
Okay. So so some of the roles that we play as nurses managing these patients, one is to conduct comprehensive assessment, especially of the pain. And of course intervene mother, which because normally pain is one of the most common complaint that this patient present with. And also we assess the vital signs and also any other non-verbal cues, ages. So pain is a significant alterations of vital signs. So you find that these patients, because of pain, may have present with increased heart rate, respiratory rates, which will be altered, increased, and even blood pressure may increase. So it's our role as nurses is to monitor that, and especially in children, we have children whereby or other non-verbal, and even for those patients who may be unconscious, so that we assess for that pain. Another role is to overcome
let me request KNH research. If it is possible, we can have Francis in our next session. Seems like he's he's having a problem with his connection, so that we can have Dr. Matilda respond to some of the questions. We will have Francis's presentation in our next session. Sorry about that. Dr. Matilda, please take it over.
No.
Okay. So just in response to some of the questions, some have been addressed in the discussion earlier in terms of options of treatment for AML. And we have intensive treatment and less intense treatment. There's an anonymous attendee who's concerned about how long it takes to treat a patient, and especially at KNH. As I've said earlier, most of the times when our patients are sent, they are sent in extremis, meaning that they have very low blood level, very low platelets, are bleeding. And then therefore, the most important thing is you need to stabilize these patients first. Sometimes they have associated infections and you have to manage that. So all that is important. And as much as possible, usually we try and also engage the families. Most of the times for patients who've not had any immunophenotyping by flow cytometry, we encourage them to do the same. And this is, again, a shared decision-making in terms of if the patients are able to afford or access that. So remember what I said that treatment of AML, irrespective where you are, for definitive treatment to be done well, the supportive treatment is an important anchor, and you cannot begin treatment if you have issues with the supportive care, or if there are patient factors which have not been sorted out. Does transfusion prior to BMA affect results? No. Many of these patients, by the time they come to us, have had transfusions. The thing that you may not be able to interpret well may be the peripheral blood film, but however, it doesn't affect. So sometimes, and thank you for raising that question, because sometimes maybe the concern is we don't want to transfuse this patient, let them go and have the bone marrow first, but we need to stabilize the patient so that they can make it to having that bone marrow. What is the lowest acceptable platelet count before starting a patient on chemotherapy or referral? What I would say, I would be very hesitant to put a number on for referral, because many times we know that unlike blood and blood products, platelets are not readily available or are available at very limited facilities. So what's happening to the patient? If your patient is bleeding, then on top of transfusion with packed red blood cells, they need platelets. So for that patient, it makes sense to hasten the process of referral, especially if you're not able to give them platelets. If your patient is just having symptomatic anemia but no bleeding, and the worrisome bleeding happens at platelets below 10, that's spontaneous bleeding. For platelets above that, it usually also is dependent on other factors. So sometimes you can have a patient with a higher platelet count and they are bleeding. Please, then that patient also needs to be referred because of platelets, or if there is a facility where they can get platelets, then let them, or if you're able to offer that, then they can get platelets in addition to the packed red blood cells. Remember, for these patients, part of the reasons they have low platelets is because their bone marrow is packed with the blast cells. So many times the question is, are we able to support this patient through treatment? And so and that is also in addition to answering the earlier question of why does it take long to start treatment? A patient who is bleeding, has low platelets, maybe you're getting erratic platelet transfusion. There is two ways of transfusing platelets. There's a single unit platelet, and there's a rich concentration of platelets called apheretic platelets, which increases your platelet count at least by 30 to 40 if you have a good unit. And if a patient gets to, it gets them above that threshold. But most of the time, if you're dealing with the regular platelets, which are separated from 1 unit of blood, then for 1 unit of platelet, you have an increment of about 4 to 6 platelets. It increases by, so if it was 3 or 2, that platelet value will increase to 7. So the platelets usually are the ones which are a challenge. How often do you do a bone marrow? You would do a bone marrow at diagnosis. Then after, if your patient is on intensive treatment, you would do a bone marrow at day 21. Some places will do it at day 14, but sometimes you find it quite early because the patient is quite cytopenic, unwell, and you really want to, and then you may get a marrow that tells you, that's a bit inconclusive. So day 21 is around the number that you didn't want to go beyond day 35 if possible. And then how often should it be done? So for example, for both acute leukemias, you induce them, you want to make sure if you're doing intense treatment that they have gone into remission, because if they have not gone into remission, then you either re-induce or you go for another line of treatment. What antibiotic did you say is the best for AML patients? So for all acute leukemic patients, the guidelines indicate that if for bacterial infection, you want a broad spectrum antibiotic, tazocine is your drug of choice. Remember, if the infection persists, you have to think about other causes. You have to think about viral. You have to think about fungal, especially in acute myeloid leukemia as well. Would you comment on BMA versus trephine biopsy? Is there a need to carry out either or both? Thank you very much for asking that important question. Ideally, the practice should be to do both if possible. Why? Sometimes you have a patient whose marrow is packed and you do an aspirate and you don't really get any cells. And a bone marrow is a painful procedure. As much as possible, you try and make it painless, by giving good anesthesia, local anesthesia. But if possible, you don't want to repeat the test. So if you do a trephine biopsy as well as an aspirate and a trephine biopsy, then for any reason, if the aspirate is aparticulate or inconclusive, then you have a trephine biopsy to work with. But I would say the second part to that question is there a need to carry out either before referring? Hello, can you hear me? Hello, can you hear me?
Yes, Dr. we can hear you.
Oh, sorry. Okay. So I would answer this question carefully and say, if you have any challenges with the diagnostics on your end, please ensure that the aspirate and trephine is done at a facility that's able to give you a reliable result, or if there's any question that we can then ask the patient to get the slides or the trephine biopsy for a second opinion, or where we can discuss with the pathologist, because that's where the challenges come in most of the time. We've appreciated when patients have come with very good aspirates and trephines, because that shortens then the time to treatment or to making decisions. But it's also been a challenge where a patient has had a procedure and maybe it was traumatic, and then we are having to repeat the procedure again. So I would say, if at your facility, there's not a clear path, there's challenge in terms of getting results, maybe the cost and all, then refer them somewhere they would get a reliable result. And if you're not sure, then you can refer them. But as much as possible, we want to encourage that we have the basic diagnostics done, but at least a bone marrow. So is KNH or any public hospital doing IHCs? So immunohistochemistry is used both in solid tumors and, as I've mentioned, the trephine. At KNH, I know for breast cancer, there is IHCs for the hormonal testing. At the moment in the university side, they have some few markers for the trephine biopsies, but there's still a lot of room for growth. That's on the in terms of at the public facility. Moi Referral Hospital has a capability for doing the immunos, I think, and the flow cytometry. I'm sure about the flow cytometries. I'm not too certain about immunos. Yes, but I know that most institutions are trying to work towards that. And I think there's something about IV fluids and, okay, I'll just read the question for the purposes of making sure you understand. During my time in oncology as an intern, I noticed that children receive IV fluids which exceeded the normal fluid allowance. I would like to know if normal, okay, the significance on a low HB. So what I would say is, in terms of IV, where we are very keen on hydration. So patients with buckets, patients with where you're concerned about tumor lysis, whether it's lymphoproliferative or acute leukemia, as I've mentioned, you want aggressive hydration. However, what's happening to your patient? If a patient has an acute kidney injury, you want to hydrate them, of course, monitoring. If your patient does not require fluid resuscitation, then overhydrating them would cause more harm, especially if already they are having issues with anemia and maybe it's been chronic and they may have a bit, so it's easy to push them to fluid overload. So I would say assess your patient well. What does your patient need? If your patient needs blood, let them get blood. If your patient maybe is hypotensive because they've also had an infection, they're having an AKI, as you look for blood, give them fluid as you pay attention to make sure they don't have any features of fluid overload. There's an issue about O negative platelets. Yeah, that's a challenge. O negative products are difficult to get, especially the platelets, even blood. There's a question about so platelets are a bit interesting. So blood, you can put blood in a cool box, but platelets are not to be put in a cool box. Platelets are transported room air. Platelets have to have a slow agitation, because if you agitate them too aggressively, you then can cause clamping or activate the platelets, and then it's like you're giving the patient water. So I think it's very important in terms of if there's no safe way to transfer the platelets, then it's better to refer the patient to a facility where they can get the platelets. I think I've tried to assess, address most of the questions. There's one last one. Do leukemia types like APML have specific genetic alterations, have a better prognosis? Yes, Felix. APML is one of your favorable risk AMLs. And for this, there is a treatment, ATRA, which is combined with chemotherapy or something called arsenic trioxide, but that's not available. And it does have a good prognosis. However, the first 30 days are very critical, because sometimes even when you have those drugs, the patients, because you mentioned earlier, they can get a lot of bleeding because of coagulopathy. So these patients, as much as we say it's a good diagnosis, the first few weeks of their treatment are very critical because they can get side effects. So thank you.
Thank you, Dr. We really appreciate. I'm sure if we had another 2 hours, we'll still keep us on the edge of our seats. This is a very timely presentation. I hope we'll be able to make time to invite you again to touch on a few areas, especially on the bit that we didn't get from Francis. I'm sure you and Francis will come through for the next session. We're looking forward to that. We really appreciate it, Dr. Thank you. So right now, before I invite Livingstone and Sarah from HENZO, I had mentioned that we are doing this in partnership with the Acute Leukemia Advocates Network, which is an international organization that puts together all the advocates for acute leukemia. And today we have Samantha Neer from Alan. I'd like to just invite her to just say a few words, just quick words of greetings, and then I can progress. Samantha?
Yes, can you hear me?
Yeah, we can hear you, Samantha.
Yes, so hi, so my name is Samantha. As Elo has mentioned, so I'm working for the Acute Leukemia Advocates Network. And I think one thing that Elo forgot to mention is that he is actually part of our board. So he has a voice, and he's making sure that the voice of the patient from Africa is well represented in our activities. And
just a moment, Samantha is joining us.
Yes. Can you hear?
Yes, we can hear you now, Samantha.
So did you hear what I said before or nothing?
No, we did. We just lost you for about a second there, but you can carry on.
Okay. So our work, as Elo mentioned, is to run the advocacy work on an international level. And on that topic, I would like to mention that we have a global survey, a patient experience and caregiver experience survey, which is coming in the next few weeks. And it will be very important to make sure that your patients and the people who are living with the patient are actually taking part in that survey, because we have very, very limited data when it comes to Africa and Kenya. So it would be very good to be able then to generate some evidence on what patients and caregivers are actually living when it comes to leukemia. So I'm sure Elo will be in touch with all of you to make sure that you get access to the link and the materials, so you can also give that to your patients in the clinics. And just very quickly, because I think there's more coming afterwards. If you have any questions or anything, you can always have a look on our website. I'm sure Elo can share the link in the chat, and feel free to contact me at any time. Thank you very much.
Thank you, Samantha. We really appreciate. Thank you for making time to be with us today. We really appreciate it.
It's an honor.
To you.
Thank you very much. And thanks to everyone for the work you are doing. It's very important.
Thank you. Thank you very much. Livingston Simiu is a member of HENZO. He's been working with the leukemia patients, and just want him to pass a word of greeting to us. Livingston.
Thank you, Elo, and thank you everybody for joining us today for this important session, especially for patients. My name is Livingston Simiu. I work with HENZO as a secretary. I'm also a patient of leukemia, but the chronic type. We call it CML. But I think Daktari has mentioned many things, important things for patients, especially for acute patients. Just my point of view would be, one thing he mentioned is support, which is, I think, the anchor of what we at HENZO we do, supporting patients and just creating awareness and general advocacy. And for that, maybe I can just say that as a patient, or from a patient perspective, is support is really important when we are walking this journey. And especially for acute patients, I know it's really tough, as we've observed here from what Dr. has taught us. So my plea would be for caregivers and survivors, some of us, to take care of those who are starting this journey, first of all, just to tell them and to feed them with hope to make their journey a little bit easier. I work in the community, and you'll find most of the time we get calls from the community on the ground of patients who want to be navigated, who want to learn more about leukemias in general. And I just want to say that HENZO Kenya is available and free and on the ground. And if you cannot reach us personally, you can always reach us through KENCO as well. We partner with them. And also at KNH, we are available for patient support, peer-to-peer support, psychosocial support, and all that. So feel free to refer us to to those who need our help in the community. We are here to support each other as patients and survivors, and to make sure that the journey is as comfortable as it can get. Thank you, Elo, for this wonderful program and session.
Thank you, Livingston, for opening your hands to support leukemia patients. Sarah Mararo is also an official at HENZO Kenya. She's also working in Kenyatta National Hospital. and she too has been working with the leukemia patients. Sarah?
Thank you, Elo. I'll just like to talk about who HENCO are and what our anticipated impact is. So HENCO is a community-based organization that has been in existence for around 15 years, supporting mostly CML patients and GIST patients, mostly because they use one medication, which is imatinib. But mostly they support them on a supportive role, that is the awareness, providing psychosocial, which is also emotional support, and advocacy, mostly to mainstream the disease, which is what we intend to do for the AML patients. Recently, we've expanded our hand to the AML, ALL, that is the acute leukemias, and we are targeting all the patients in the country. So our anticipated impact will be to improve awareness of the acute leukemias, to expect a behavior change, especially when in medics in seeking early treatment, screening of patients, and to improve chances of detecting and treating the disease early through CMEs like this, webinars and whatnot. We also advocating for availability of diagnosis, treatment in the in the long run, so that we can reduce the cancer burden. So we'd like to thank Alan, KENCO, KNH doctors and nurses. Let's make this work. We know it's a long, looks like a long shot from now, but we know there's room for us to make a change as we try and support the acute leukemia patients. Thank you.
Thank you very much, Sarah. We appreciate your work in making life bearable for leukemia patients. And with that, ladies and gentlemen, we come to an end. But before you go, I promised some announcement. Maybe KNH research team can share briefly about how to get our CPD points.
Yes, thank you, the team from HENCO, also the team from KENCO, and also Dr. Matilda Ugondi from KNH for your wonderful presentations. We've really learned a lot. Right now, we'd like to address the CPD points. For PPB, you are requested that if you have missed points, kindly email knhcpd@gmail.com. Our team will be able to sort you out through the email that you've sent, and we'll be able to look into the sessions you've attended and to ascertain why you haven't received your points, and if there's any challenge, we'll be able to offer assistance. Same goes for KMPDC and NCK as well. For COC, we are still working with the council for integration, or so that we can be able to issue your points from our end. We had earlier been sending the attendance lists to the COC, but since they have upgraded their system, we're still waiting for integration so that we can get the rights to issue our attendees the CPD points. For any other inquiry, kindly also you can always reach out to us through knhresearch@gmail.com or KNHCPD, and our team will be able to sort you. Thank you once again for joining us, and do have a wonderful weekend ahead.
Thank you very much. We really appreciate everybody for joining. We will be getting back to you with communication on the next similar trainings from KENCO and HENCO. Thank you very much and goodbye.